profit organization, parents as teachers supports professional and organizations working with families with young children from prenatal to kindergarten, operating across 50 states and 6 other countries. And the organization is renowned for its evidence-based home visiting model, initially launched in Missouri and subsequently adopted on a broad scale nationally and internationally. And currently, Allison serves as a co-investigator for 6 National Institutes of Health grants, collaborating with researchers from SLU institutions such as Washington University, Northwestern University, New York University, and the University of Abuja in Nigeria. And she also actively contributes to various national advisory groups related to family support and maternal and child health. She holds a master's degree in public health from St. Louis University and serves as adjunct professor here at the College of Public Health and Social Justice. Her unwavering commitment is driven by the belief that every child deserves a strong start in life. She tirelessly advocates for the well-being and success of all families. And Allison, we welcome you to take over.
Thanks so much, Sable, and thanks, Min, for the invitation to join you all today. I didn't realize you would read the bio, so that's a little, but good, helpful, I think, to have you get a sense of who I am. So let me make sure. How is my screen looking? Look okay? Okay, all right. Well, thanks again for all joining me today for this talk, and thanks again, Sable and Min, for the invitation. So as just one kind of proud moment, I am a SLU alum in the MPH program. My focus was epi and behavioral science, and so really appreciate all that SLU did to set me up for my success in my career. So today's talk, I'm going to start with some context on home visiting, what it is and why it's important, share more information around parents as teachers, our home visiting model, our reach, and the model more specifically. And then I'm going to share some insights into how we're continuing to innovate on the maternal and child front. And then we'll have some time at the end for question and answer. Great. So first, let's kind of talk about why. Why does home visiting matter? So this data comes from the National Home Visiting Resource Center, and they look at data and track data across the United States in terms of the need and where home visiting currently is residing. And so according to that data in that yearbook, there's over 17 million families that could benefit from home visiting services. And so when we're talking home visiting services, we're thinking about families prenatal with a child through kindergarten. So through that first kind of kindergarten year. And there's also 22.6 million children that could benefit. So all families with young children can really benefit from home visiting services. And we also know that families that are experiencing stressors could benefit most. So of the 17.3 million families that could benefit, 48% of those families have at least one stressor. So that's almost half. And 18% have 2 or more stressors. Now, so that's kind of the need. And in terms of where home visiting currently is, it's estimated that home visiting services is serving only around 3% of those with 1 or more stressor. So we are really not serving the broad need that there is in the community. So this might be a slight underestimate, as homegrown models may not have represented their data. But Parents as Teachers is the most widely replicated evidence-based home visiting model, and it represents about 1/3 of all families served in the United States. The images on these slides are from the Harvard University, and they show neurons in the brain. And so this is, again, part of the why home visiting matters. At birth, you can see there's already neurons there. And then it continues to double in size in the first year. And by the age of 3, a brain has 80% of its adult volume. So those first 3 years are so critical for brain growth. And you probably heard the saying, a children's brain is like a sponge. Well, in fact, their synapses and how they're formed are forming at a faster rate during those early years. So it's not quite far from the truth. So that rapid brain growth is so important in those first 3 years. And we also know that stressors can significantly influence brain growth and the development of a child's brain in the first early years. So we start reaching families prenatal. The earlier we can get them, the better, and can continue to support them in those crucial years. So a little bit about parents as teachers. Our vision is that all children will develop, learn, and grow to realize their full potential. And our program, as I said earlier, supports families prenatal through with a child through kindergarten. And we do this through a 2-generational approach. And that we live that out through our mission, which is to promote the optimal early development, learning, and health of children by supporting and engaging their parents and caregivers. We serve the entire family. So while this talk today says maternal and child health, the role of fathers, the role of other partners, foster parents, other caregivers, aunts, it's so important. They're all essential in supporting that child in those early years. And so we engage the entire family in our work. So I'm going to talk a little bit more about who we reach and who we are. Parents as Teachers started in St. Louis, Missouri in the 1980s. And our founder, Mildred Winters, was working in the school system and noticed children were coming to school not ready to learn. And she said, we need to start earlier. And we need to reach the children's first and most influential teacher, their parents and caregivers. So after some early research, our model rapidly scaled to other states. As stated, we are in all 50 states and other countries as well. So we train and certify nearly 8,500 professionals who provide supports to families in all 50 states. And also Canada, Germany, Australia, United Kingdom, Switzerland, Guam, and not listed here. We are expanding to Nigeria, and that could be an entire other talk, but not for today. We provide support to over 172,000 families and 205,000 children, and we deliver almost 1.7 million visits annually. We conduct 186,000 child developmental screenings, make resource connections to other community resources, and host group connection events. And I'll talk more about what our model is, but that's a little bit about our reach. We also have a significant tribal footprint. So we are uniquely addressed to support American Indian and Alaskan Native families by leveraging the strengths in their communities. Our program is culturally specific and locally implemented, and we use professionals from the community that can honor the cultural heritage, tribal teachings, practices, traditions, values, beliefs, and really incorporate that into in the work with families, which we call personal visits. So our tribal affiliates, they really recognize and respect and engage with their tribal elders and other leaders in supporting their programs. And as you can see, we have an extensive footprint that reaches to 111 programs in tribal communities across the United States. Any family serving organization can become an affiliate organization. There's funding available through federal, state, and local governments, as well as philanthropic organizations that really make home visiting available. And so it's free for families, free and voluntary. Our highly trained professionals, we call them parent educators or home visitors, are hired from the community. They speak local languages, and they are similar in demographics to the families that they're serving. And those professionals are housed within organizations. And so they aren't employed by the National Center, my organization. They are employed by their local organizations. And those organizations can be social service nonprofit agencies, school systems, and that's how Parents as Teachers is most often operated in Missouri. It can be implemented through health departments or hospitals, tribal government agencies, family resource centers, housing authorities, so on. Some more data about the families that we serve. So I mentioned we serve the whole family: grandma, aunt, uncle, father, siblings, anyone supporting the child or the children that are in the home. And of the total families we serve, 82% reported having one or more stressor. And some of the common stressors are low income, high school diploma or equivalent not attained, a parent with mental health concerns, young parents, families experiencing substance use disorder, a child with a disability or chronic health condition, or a parent with a disability, chronic health condition, families who are recent immigrants or refugee families, families experiencing unstable housing, those with a history of child abuse, neglect, intimate partner violence, and so many more stressors. And nearly 20% of our families are enrolling prenatally, and I'll talk more about our work on the prenatal front in a moment. And then 49% of families are enrolling with at least one child under the age of 1. So there's other home visiting models that will only serve first-time parents. We can serve families with children with their second, their third, their fourth child, a foster child. So we, again, have a lot of flexibility in the criteria of who we serve and support. I'll give a brief description about our model components to help you understand what does home visiting look like? What is it? So we have 4 components that are interactive and interact together. The first and often most known for is personal visits. We call them personal visits, but they're also known as home visits. We call them personal visits because we meet families where they are. So it can be on the ground in the home, and it can be virtual mechanisms. Prior to the pandemic, we did a virtual pilot with the University of Southern California, which I won't talk a lot about today, but we continue to still meet families virtually when needed. Personal visits can also happen in shelters or in community centers or parks. Again, we meet families where they are. The second component of our model is health and developmental screenings that happen for both the child, the caregivers, and families to identify delays, concerns early, get them connected to resources, identify mental health concerns and get them connected to resources. So really early identification and getting the support that might be needed. The third component is resource referral, which you've heard me mention a few times already. Our affiliates have a network of community partners that they may refer families to, including food banks, diaper banks, shelters, mental health services, and so on. And the fourth component is group connections. And this is where we bring together families to interact and engage with each other on around different topics of interest. And the topics typically come from the families. And it's a place to create social connections and connectedness. Our model has an important theoretical foundation underpinning it. For those of you that are students, you hear a lot about theories and how does that relate to practice. So in practice, you use theories to inform the work. And so we have a kind of a strong theory foundation that includes things like systems theory, like ecological systems and family systems. And we also use a life course approach. There are also interpersonal theories like social cognitive theory, social support, attachment, attribution. There's also interpersonal theories like stages of change, self-efficacy, goal setting, empowerment. And most importantly, we address the needs of the families first and foremost. So Maslow's hierarchy of need is essential, addressing and supporting the families and their needs. And we also utilize a strengths-based approach, using the strengthening families approach, bringing out the strengths of the families that we work with. We have a very robust research-informed curriculum and guidance that's used within our model. And this covers 3 areas of emphasis that are illustrated in this diagram. So those are parent-child interaction, and these are things like activities, book sharing, play. There's development-centered parenting that focuses on developmental topics like attachment, sleep, safety, health, nutrition, transition routines, healthy births. And then there's family well-being, and this covers things like basic essentials, education, employment, physical health, mental health, early care education, relationships. And at the center is really where the three areas of emphasis come together around the child's development. So monitoring the child's development and thinking about the parenting behaviors and how parenting behaviors can influence and support the child's development. So this just kind of illustrates the content we have, and our curriculum has over 4,000 pages of content in these areas that are outlined in this diagram. Our curricula is translated fully in English and in Spanish, and we have many parent-facing materials that are also translated in 9 other languages. We update our curriculum more than once a year to keep it up to date with the most recent research. We also have implementation guidance for our affiliates on how to deliver the model with fidelity and quality, but also remaining flexible to ensure you're meeting the needs of families being served. We have planning tools that support professionals in the work, and also documentation tools and a data system that our affiliates can use where they can document services and help tell their story about how they're having impact on families and children. So there's a lot on this slide, but the key takeaway from this is recognizing that within our model, we know that our affiliates are going to be at various stages of implementation. And so we use the Fixin's implementation stages to inform our work. And we have resources at each level, depending on where an affiliate might be at. So they might be at exploration of the model. They might be at program installation. They might be at initial implementation, full adoption, innovation, or sustainability. And we have resources that support affiliates anywhere and hopefully moving them across that cycle of their stage of implementation. And then our affiliate structure also operates within a layered implementation system and structure. So families are at the center and their participation in the model is voluntary, but our model is designed to hear their voices and build upon their interests and tailor to them and build upon their strengths and utilizing their strengths. Our parent educators bring their own set of skills and their own background and perspectives to the work with families. They are operating within local programs and organizations that have their own policies and procedures and recommendations around parents as teachers. And those local programs are operating within communities and state systems and tribal reservations that might have important factors that are considered in the local work. And then kind of on the outskirts is the National Center, which is my organization. We are the model developer. We also collaborate on research and learning, continuous improvement, and inform the resources and support folks at all of these levels in that implementation system. At the model developer level, we also define model fidelity and quality. So to carry out the parents as teachers model in a way to achieve the outcomes, affiliates have to document services, monitor fidelity, quality, evaluate their program, and engage in continuous improvement. And so we have essential requirements that talk about like dosage. So how many visits a family should get based upon their stressors. We have other areas like caseload size. How many should be on a parent educator's caseload? Supervision, it's important to get supervision structure. Screenings, when should screenings be conducted for families? How many group connections should happen? How many resource connections were made? And are you following up and supporting them with getting connected to services? And then we have our quality standards, which are more like higher level. And we measure this for our affiliates every 4th year of implementation. So they go through what we call a quality endorsement and improvement process. And they're measuring things like intake enrollment and process policies and procedures around that, how they're engaging families, how they're documenting families, confidentiality, safety, so specific things that they're addressing in their specific community to support families and children. And fidelity and quality are important because they support us in establishing an evidence base for our model. So our model is recognized on many clearinghouses. You can see a few listed on this slide. We have US-based and also international recognitions. And in order for a program to get funding, they have to demonstrate that they're meeting a model that has sufficient evidence. And so it's important that we keep up with the trends and the evidence to make these clearinghouses so that programs can use our model in communities. Otherwise, our scale wouldn't be as large as what it is. So we are backed by evidence. We have 8 randomized controlled trials and another one underway currently. We have 22 peer-reviewed outcome studies with many more kind of outcome studies in progress as well. And all of our evidence are directly connected to our 7 model goals that we have for our programs. And the goals include increased parent knowledge of early childhood development and improve positive parenting practices. Some outcomes in this area are parents show greater sensitivity towards their children. They're more likely to read to their child. They're more likely to have books in the home and have a safe home environment. And they're more involved in their child's school and education later. The next goal is provide early detection of developmental delays and connection to services. Annually, Parents as Teachers Network identifies approximately 32,000 newly identified developmental delays or health, hearing, or vision concerns. And then we connect families then to early intervention services or other services they need so that they can get the support. The next goal is improve parent, child, family health and well-being. So we are so excited. We have a research study that happened in Zurich, Switzerland, where they did cheek swabs on children at age 3. They took their DNA and saw that parents as teachers, we interrupt the harmful effects of early life stress on brain, and we have biological effects on children. That is powerful. Not many people can say they have DNA evidence of effects, and we do. Children are also 5 times more likely to be fully immunized. They're more likely to meet the American Academy of Pediatrics well child visit recommendations. Parents and families demonstrate less stress from participation in the program. And when we have a focus on, we've done some work on health, obesity prevention, and we've shown significant reduction in obesity and diabetes, as well as improving dietary intake and parental modeling. So those are the outcomes in that improved health area. We also have evidence of preventing child abuse and neglect. So Parents as Teachers had a 22% decreased likelihood of child maltreatment substantiations measured by Child Protective Services data compared to those that weren't in Parents as Teachers. And also Parents as Teachers participation was associated with a lower likelihood of re-involvement with Child Protective Services when there was a prior involvement. So we prevent child abuse and neglect by supporting the parents and caregivers. Increase children's school readiness and later success. So we have evidence supporting the child's demonstrating adaptive behavior, better self-control, doing better on standardized test scores later in school at 3rd grade and 6th grade on math, phonics, reading, writing, as well as fewer absence rates and fewer suspension for children in the program. Improve family economic well-being. Education and employment goals are among the top 5 goals that are set with families in our program. And we see that caregivers are more likely to gain employment, enroll in high school, and enroll in college. So we are improving and supporting family economic well-being. And lastly, strengthen community capacity and connectedness. I mentioned referral network and systems. So we collaborate with our referral network and make referrals to them and show that we have increased referral uptakes in communities. Additionally, we create social support systems through our group connection work, and parents are engaging in other activities within their school as well. So lots of evidence that support our model goals that's important for us to look at. So briefly want to mention the role of the National Center, which is where I work. So we are the model developer. We oversee the research learning, the training, curriculum development, implementation guidance, the fidelity standards, measurements, all of the things I kind of just talked about. We also support advocacy and policy for issues that are impacting families and children. We support branding and communications and fund development. And we also have a staff within that provides direct services in our backyard, providing support in St. Louis City and St. Louis County. And they really serve as a learning laboratory for us to understand some important and emerging issues. Now that was a lot of background information around parents as teachers and who we are. So I want to shift to talking about how we're continuing to innovate in the maternal and child health space. It's likely that many of you are familiar with this, the maternal mortality crisis. And you can see the data on this slide. You might have seen this in some of your other work from the National Center of Health Statistics, trends in maternal mortality. And over the last few years, they continue to rise in the United States. And health disparities are also continuing to widen. In 2021, the maternal mortality rate for non-Hispanic Black women was 69.9 deaths per 100,000 live births. That's 2.6 times the rate for non-Hispanic white women. Black women are more likely to die than white women. The rates are also, although not represented here, for American Indian, Alaskan Native non-Hispanic women, also higher than white and Hispanic women. We know that there's various factors that are contributing to the maternal mortality crisis in the United States, and the disparities might include access to quality healthcare, socioeconomic inequalities, racial ethnic disparities, lack of comprehensive prenatal care, and other systemic issues within the healthcare system. And it is also estimated that 60% of maternal deaths are preventable with appropriate care and interventions. So some of those leading causes that are preventable are hemorrhaging, hypertension disorder, infections, inadequate prenatal care, gestational diabetes or weight gain, and more. So parents as teachers, we've always been supporting and serving families prenatally. A family can enroll at any time prenatal through kindergarten. Over the last several years, we have observed an increase in the percentage of families enrolling prenatally. Over 10 years ago, we had less than 5%, and today we're nearly 20% of families enrolling prenatally. So the maternal mortality crisis and this data together are showing that we need to be better supporting and families prenatal in that prenatal postpartum period. And so this helped lift up for us the need to critically think about our work supporting prenatal and postpartum families. So I'm going to talk a little bit about the journey that we've been on to understand the landscape and what's happening. So in 2018, we formed an internal working group to explore this topic further and formalized a relationship with the Research and Evaluation Unit of Brazelton Touchpoint Center and the Division of Developmental Medicine at Boston's Children's Hospital. And they supported us in our learning. So we first started and conducted an extensive literature review, reviewing nearly 3,800 articles published between 2015 and 2020. For any of you that have done lit reviews, you know that that was a massive undertaking. A lot of research went through and synthesized. But it was important for us to have a deep understanding of the issues in research to inform us on our next steps. Some of the themes from that work were physical and mental health morbidities were commonly co-occurring. As stated before, that there's several groups are disproportionately impacted by maternal and infant morbidity mortality. So low-income individuals, race, ethnicity, individuals of color, LGBTQ plus people, individuals with disabilities. Also, many risk protective factors for maternal and infant mortality were present before a pregnancy even was conceived. So pregnancy is not even early enough. So how do we start earlier? How do we get to preconception care? Maternal and infant morbidity mortality can occur at any point during pregnancy, delivery, and postpartum period defined up to 1 year. There is research that suggests home visiting may predict lower rates of certain types of maternal and infant morbidity and mortality. And that strategic collaborations between families, home visitors, and medical providers, and other community health workers like doulas are really essential. One specific example from the literature. So while a goal during pregnancy, if a mother is smoking, a goal might be to get her to quit smoking. But there was a lot of research pointing to the important role of reducing smoking. So while we might be trying to support quitting, ultimately, the important awareness that a home visitor would understand of reducing and that role it can play in educating the mom when there might be. It showed a huge role in reducing the risk of stillbirth. So that was an important research nugget and just like one example of the snippet of things that we learned from that lit review. We also surveyed our network, our parent educators, our supervisors, and learned a lot from this. And one key finding we learned is that parent educators, they felt really prepared to discuss issues related to parent-child interactions, childcare, developmental delays concerns, and they did not feel prepared to talk about intimate partner violence, substance use, mental health problems, pregnancy complications. And so these are important issues that we needed to understand. We also conducted focus groups and surveys with our network to understand what resources they were using and what some of the gaps were. We looked at family level data. So I mentioned we have a data system. We explored that data to understand what families, some situations and circumstances families are currently experiencing, and also conducted interviews with families. And lastly, we documented local innovations that are already happening. So looking at what are some successes already happening in communities. And I'm going to talk about the last two on the next few slides. So to lift up one key finding from the family data trends we looked at, we saw that among pregnant persons enrolled in parents as teachers, nearly 1/3 used nicotine, and 14% used marijuana, and 8% consumed alcohol. And then there were lower rates of reported for other types of drugs. The reported rate of nicotine and tobacco and marijuana was substantially higher than national samples, as you can see from the data from the American Congress of Obstetricians and Gynecologists, also known as ACOG, that stat where they said 7.2% of women who smoked. So some of this data, when I mentioned about smoking, reducing smoking, how can that have a significant impact when we know that 31% of ours are smoking? That's huge. Another important role for parents as teachers that I mentioned is that we are not only a model developer, but we are a direct service provider in St. Louis City and St. Louis County. And this is kind of documenting the innovations. We have been innovating within our affiliate we call Show Me Strong Families. We've been innovating so much so that we received news coverage in the New York Times, front page, above the fold, which is significant. We were featured in CNN, on NBC Nightly News, in a PBS documentary on birthing justice, and a segment that's still to be released on Investigate TV. So our affiliate has been integrating full spectrum doula services within the Parents as Teachers model, and offering it for free for families in the program, and really looking at how we're supporting pregnant postpartum families. The doula work has been an important lens to provide to our work, and we know others in the country are doing some of this work too. And so we wanted to document it. I wanted to share one kind of quote from a mother. So this mother, she was age 30, and she was featured in the New York Times article. She was experiencing intense swelling in her feet after the birth of her second child. The doctors told her it was normal and it should subside in 10 days, and that she should drink water, elevate her feet, avoid fried food. When it hurt for her to stand up, she sent a picture to her doula and her parent educator, who was alarmed and urged her to go to the hospital right away. Mom was admitted to the hospital with postpartum preeclampsia and dangerously high blood pressure and spent 3 days in treatment. The mother quoted, "If it wasn't for you, I wouldn't have ever gone to the hospital." She told her parent educator, "I would have just spent 10 days dying." And the parent educator responded, "I wasn't going to let that happen, not on my watch." So just powerful stories that illustrate the impact, and sometimes that somebody can advocate and help you find red flags that might exist in pregnancy or postpartum and get you connected to services for support. So what does all this mean for parents as teachers and home visiting? Well, our role as the organization is to translate research, learning, all of that information that we've gathered We sift through, we think about what that means for strategies for our field, how to best convey that information, what skills are critical, what supports are needed, how do families digest that information? And all of that listening comes together in the development of new resources. So we've rolled out new resources to our network, advanced training that address some of the issues that were commonly lifted up, implementation guidance, and new curriculum content. And so as we're integrating all of these into practice, certainly that feeds back into more research opportunities, which I'll talk about. And while there's too much on this slide to illustrate, just want to point out that through this process as well, we developed an overarching logic model that describes the inputs, the activities, outputs, and outcomes of our prenatal postpartum work that's implemented within the evidence-based home visiting model. So now, certainly, we've gone through this process to learn more about the needs, created some resources, and we're going to engage in some ongoing learning around this. Along with our collaborators at Brazelton Touchpoint Center, we've launched an evaluation to look at the process and implementation. How are the new resources being integrated and how are they working? What are the outcomes? What are the impacts? What are the strong system structures that are needed in the communities? So we'll use a multi-method evaluation, both qualitative and quantitative data. We'll collect data from parent educators, the home visitors, supervisors, and families, and we're estimated to have around 300 families in this study. Some of the key questions we're seeking to answer are listed here. How are the resources and training working? How and what are important program, provider, or system factors that are going to influence success? How are we changing knowledge and skills? When there's doula services, so we have a subset of affiliates doing doula services and a subset not. When doula services are integrated, how are those working and influencing, and what are the best practices in integrating doula services alongside home visiting? And then overall, what are the family outcomes and children outcomes we're seeing? Hopefully a reduction in maternal and infant morbidity mortality. So while Parents as Teachers has a lot of evidence already, it is critical that we continue to engage in ongoing learning and continuous improvement. This helps make sure we're meeting the needs of families, and learning is a journey. So we can't just stop and keep our model the same as it was created 30, 40 years ago. We need to evolve. We need to continue to meet the needs of families and listen to the families' voices. We need to support tailoring for services. And we need to continue to develop more evidence, because all of these things bring up more questions. And it's important that we do this because services for families don't look like this. They are not linear. Not all families need the same thing. And so our goal through some of this work is to continue to learn how services can be tailored to meet the unique circumstances of families and truly tailor services supported by evidence. While today I called out a specific research partnership with Brazelton Touchpoint Center, it's important that we recognize we can't do this work alone. So through partnerships, we've been able to go farther. We've found experts in various topic areas, built collaborations and research and learning in those areas. And you can see icons for partnerships that we have projects underway with currently. And some of them have more than one study underway. I wanted to end with this quote that I think is really important. I was able to go to a Nelson Mandela exhibit recently at the Science Center in St. Louis, which was awesome as part of a leadership day. So it's kind of fresh on my mind. So this quote emphasizes to me that education and learning are transformative processes, and that learning is a journey, and it's an important one, and it can have a positive impact and help change the world. And for parents as teachers, our learning journey will continue until we reach our destination, which is our organization's vision, that all children will learn, grow, and realize to develop their full potential. Thanks again to Min and Sable for having me present today. We'll have some dialogue Q&A. My contact information's on this slide. If you have any questions, I'm happy to take them.
Thank you so much, Allison, for that great presentation. And everyone else, you're welcome to unmute and ask Allison a question or share your thoughts.
Hi, Allison. Thank you so much for the presentation. This was amazing and so informative. I have two questions for you. One is, you mentioned that the materials have been translated to Spanish and other languages. Do you know if anyone has looked at the cultural adaptation other than just the language? And my second question is, how can we get in contact with you, or what is the best process if we want to collaborate, or if we have an idea, or because I have 20,000 things I would like to do with y'all. So those are my two questions.
Thanks so much, Maria, for those questions. So we certainly have a lot of research actually through, it's called our FACEwork, Family and Child Education, which is implemented through 51 Bureau of Indian Education schools, so BIE schools within tribal communities. And we have a 35-year evidence research project with them, looking at not only language translation, but culture. And so while we have content in our curriculum, we have handouts that guide and pose thinking about culture, adapting, asking questions. So we're not going to be able to reflect all of the different traditions, cultures that a person might have. But if the parent educator goes in asking questions and seeking to understand, then they can build from that foundation and really create a place of learning and understanding together. So for example, cradle boarding. Safe sleep practices have been happening for generations. And the American Academy of Pediatrics came out with recommendations, but there was already practices in place long before in our tribal communities. And so understanding and recognizing that is an important part of the work. And so we start from a family-centered approach of understanding where the family's at and building it within. But certainly we have a lot of that evidence from the 35 years of our work in tribal communities that shows how those cultures, traditions, and when we look at like educational outcomes, sometimes people think of English. We're not coming in trying to get everybody to a Euro-white English perspective. We want to your language. What language is important to you? And are we measuring that in an important way? Because some languages aren't written, some are only spoken. And so we really try to factor that into the evaluation work to make sure we're not emphasizing things that might undermine cultures and traditions and communities. So that's the first question. Yeah.
And I guess I should have introduced myself. My name is Maria Romo Palafox. I am an assistant professor from nutrition and dietetics, and part of my work is on dietary acculturation. So how immigrants' diets shift and change when they move to the US. Currently, I have data on a group of Hispanic and I am from Mexico. I was born and raised in Mexico City, moved here as an adult. So I was fully cooked Mexican by the time I got to the US. And I've gotten some pushback, interestingly, about like grouping Latinos as one in terms of diet. And it's been very interesting because, people are trying to avoid the whitewashing, but on the other hand, I'm trying to say, well, I'm part of that group, and I'm telling you, there are things that are common. And so I would love to discuss like what we've been finding, and if there's anything that we could help with. The way at least the participants talk, and I've heard this from different cultures, is like the American recommendations and then my recommendations, right? They talk about like, oh, I fed my child American food, or I fed my child Salvadorian food or Mexican food, or right? There's this like split between me and the US that's been interesting to see in diet. I don't know how it shows up for other themes.
Yeah, thank you, and would love to connect further. So if you want to reach out and email me, we can certainly have further conversations on this. And thanks.
I don't have a question, but I just want to thank you, Allison, for taking the time to speak with us. And it was a really great presentation. I think I speak for everyone when I say that, like, we learned a lot and we're really valuable to have you as a local resource.
Thank you, Avery. Appreciate that.
A wonderful presentation. I am greatly impressed, moved by your achievement and by this such an important implication of your model, your program. And also your passionate spirit encouraged me. Thank you, Allison. Thank you.
Appreciate that.
I do have questions. I hope I have more time, have a one-to-one conversation with you. But I, I believe other people have questions. I just raised one question. In your presentation, you mentioned that there was 8 independent randomized trial,
Yep.
trained in the medical school. I always fascinated in randomized clinical trial, no matter clinically in the hospital or community.
Yeah.
Can you share a little bit of this randomized trial? Have this study been published? How can I get the publications? I really wanted to learn.
Yeah. So that's a great question. And yes, they're all published, and some of them are longitudinal and ongoing. So the study I mentioned that did DNA cheek swabs on children at age 3 and saw biological impacts, they're following the children long-term and actually starting a follow-up at the middle school age. So they've found findings on self-control and behavior that continue to remain effects constant following the children through elementary grade, which is amazing. So they're following the children long-term. That's like one example. I can certainly share the other publications, and maybe if I can multitask, I can grab the link and put it in the chat. The other thing, to your point, randomized control trials are so tough in community-based work. And honestly, there's some ethical considerations around denying a family services. However, they are required for these clearinghouses to be evidence-based. And so we have to continue to do randomized control trials. And there was one study recently done that in the intervention group, 21% of families never got a visit. So 21% in the intervention group never got a visit, yet you still have to look at the outcomes as an intent to treat sample. And so they leave them in. That data was made publicly available. We explored it, pulled out the 21%, did propensity score matching, so getting a little technical here, and saw that our outcomes grew. We had more outcomes when you remove the 21%. Now, it no longer makes it a randomized controlled trial. It's now a quasi-experimental study design because we have tampered with that kind of intervention group. But so the clearinghouses won't look at it. However, it's a more accurate picture of what's happening on the ground. And so I would love to see how we can move the field away from thinking about randomized control trial as the gold standard, because it's a tool. It's a tool in the toolbox, and it really should not be the gold standard anymore for community-based work. Maybe you need 1 or 2 to get established, but to continue to invest in it is a lot of time and money. And there's so many other statistical designs and methods that could really be applied. And I could go on a soapbox on that, as you can tell. So I put a link in the chat to our Parents as Teachers website, the research results section. If you scroll down that page, there's a research bibliography that has all of the research that's been published on Parents as Teachers. We have a lot more kind of in the works under review that we'll be able to add to it soon.
Yes, thank you, Allison. What do you share with us? It sounds so familiar. Randomized clinical trial to be used in the community setting. There were always challenges, as you point out. I found so many common languages with you. So hopefully after I finish homework reading your published these papers, I may go back to you for further brainstorming, tightening, okay?
Would love that.
Thank you very much.
Thank you.
We have a question from the chat. Is there volunteer opportunities or other ways for master's level students to get involved with parents as teachers?
Yes, great question. Thanks for lifting that up. I'm having a hard time navigating all the spaces. So we have internship opportunities through the National Center, and on our website, you can find a place to apply to be an intern. Darnell Austin and Abigail Edwards, both on here, did a practicum with us this summer. Aaron Miller also did. So we had 3 SLU MPH students that did an experience with us this last summer. It was incredible. They were kind of we created a learning cohort. We also had another student in the MPH program at WashU at the same time that did it. So we had 4 students altogether. So we welcome students, opportunities, and I want to invite you to, while we have some ideas listed on our website, we can be creative. And so if you have a need and interest, let's talk and create that dialogue to create an opportunity that fits for your focus area, because we might not have thought of all the potential opportunities that exist. And Darnell and Abby could share, their thoughts, and which I see Abby did.
Okay. Yeah, that was great. And thank you for speaking to practicum opportunities and the volunteer opportunities. I think we have talked a lot about parents as teachers when I was doing my MPH about the positive effects it has had on children. And I remember my group, we really talked about how parents as teachers, home visiting model has reduced child abuse and child neglect. But I wonder if, because you have so many different affiliates, does that affect the model delivery? And that is one of my questions or one of my thoughts. I know that you tailor the visits according to the family, but overall, does the different affiliates that you're associating with affect the delivery of the model? Sorry.
It's a great question, Sable. And certainly I think the implementation systems is a good illustration of, we have criteria structures for fidelity, but we often offer a lot of flexibility because we know things need to be culturally appropriate and tailored to the community. So when an organization is going to become an affiliate, they fill out a comprehensive affiliate plan that describes to us their partner, their structure, their services, needs, data. Like, why do you need this? What are the goals you're trying to achieve? So we listed 7 model goals, but those might not be goals of all programs. They might have 3 of the 5 goals, so what are the needs, and making sure it's established in the voice of the community and evidence from the community. And certainly then we have structure that they have to meet, and that is all backed by research and evidence. So we have essential requirements we measure annually, and then every 4th year they go through a comprehensive quality endorsement improvement process where we do in-depth file reviews, we do interviews with stakeholders, supervisors, and they have to demonstrate they're meeting 81 quality standards. And so we have an extensive review process of what it means to implement with quality. And I will say that wasn't always there. So early on when we started in Missouri, in St. Louis, it scaled quickly, and it scaled a little too quickly. And what happened is we were seeing early evidence was, what's happening is not consistent at all. So we had to really be thoughtful around, what does implementation mean, and roll out requirements and collect data to measure it and move people along to come into that. And so it took us some time, but it was because we were born out of the needs from the community and rapid scaled versus created from an institution, which certainly can be rooted also in community, but it was born differently. It was born out of a need. So the quality piece has been something we've been thinking about for a very long time. because of that early evidence. And now we have these structures in place, but it is going to look different in each community, and it should, because the communities should be factoring in the things that are important to them, thinking of the partners, the resources. So in a frontier community in Wyoming, it's going to look very different than in St. Louis City. But structurally, and some of the process, those are the things that are going to they're going to be the same and consistent. And so those are the elements that we measure in our process. And that might have been long-winded, and happy to have follow-up, Sable, if you're more.
No, that's a great question, answer to my question, and it does answer my question. I think that maybe a related question that I have is earlier on in your presentation, you talked about how there's a great need. So there's about 17 million families who really need parents and teacher services, but then we have much less than that who have access to it. And I wonder if the different affiliates, the reason having different affiliates is associated with that, because I understand that in Shelby County, Tennessee, parents and teachers is provided by the health department.
Yeah.
And in St. Louis City and St. Louis County, it is provided by the school district. And I wonder if in your data, do you see that the reach is different depending on who is providing the services, which affiliate is providing the services?
Yeah, I think definitely the structures and systems could be different in each community. And we don't have like research specifically on local implementing agency type. But we are seeing that, the agency type doesn't influence their ability to meet the standards or quality requirements, but what priority focus area might be different. So health departments might be more interested in a connection to health, or school might be more interested in the education piece. And so the kind of focus might be a little different, but ultimately getting to the kind of the same common goals and outcomes. But more research to be done, certainly, on the influence of local implementing agencies and systems and communities and the structures, so resources available and so on. Thank you.
Thank you so much for a wonderful presentation, really educative and informative. And thank you everyone for joining us. We had a great time with you today. Thank you so much.
Yes, thank you everyone. And I put my email in the chat and invite anyone to reach out to me for further conversations or questions. So thank you so much.
Thank you. Have a great day.
Yeah. Take care.
Bye-bye.